So good evening, welcome to the first tutorial for the year 2025. And we'll be looking at a very important topic, management of respiratory tract infections. All right, so we're going to, these are learning outcomes. We're trying to differentiate between upper and lower respiratory tract infections. We'll list some common causative agents, viral, bacteria, fungi, and some atypical pathogens. We'll explain the pathophysiology of respiratory tract infections, recognize common symptoms, investigate, and investigation necessary to diagnose respiratory tract infections. And we outline the management of different respiratory tract infections as it pertains to us anesthesiologists and intensivists. All right, so broadly, respiratory tract infections are those infections that affect the respiratory system, all right, which includes the airways, the lungs, and its associated structures. These infections may range from mild, self-limiting conditions to very severe, life-threatening illnesses. All right, they are among the most common reasons for outpatient visits and hospitalizations, and they can contribute significantly to global M&M, particularly in children under 5 years and older adults. Okay, broadly, respiratory tract infections classified into two: the upper respiratory tract infections and the lower respiratory tract infections. All right, if you see the diagram or the picture on the right side of the screen of the slide, you'll notice that the upper respiratory tract infection affect the nose, sinuses, the pharynx, and larynx. All right, and the common examples are the common cold, sinusitis, pharyngitis, tonsillitis, and laryngitis. But we're going to just focus on some of the common ones that we see more commonly. The lower tract infection, lower respiratory tract infections affect the trachea, the bronchioles, and the lungs. And here you have, infections like acute bronchitis, pneumonia, and bronchiolitis. But we're going to focus on the common ones as it affects us. All right, so broadly, we're looking at the etiology, all right, and we're dividing them into upper and lower respiratory tract infection, all right, and the mnemonics is RAFC. So the upper respiratory tract infections, the leading cause is rhinoviruses, which are the leading causes of common cold. We have adenoviruses, which cause pharyngitis, commonest, conjunctivitis, and more severe infections in children. We have the para-influenza viruses and the influenza viruses, which cause croup and other mild to severe upper respiratory tract infections. The lower respiratory tract infection, the causative agents include the influenza viruses, which are responsible for seasonal flu and severe pneumonia, severe viral pneumonia in vulnerable populations. We have the respiratory syncytial virus, which is a leading cause of bronchitis and pneumonia in infants and young children. All right, we have our popular notorious COVID-19, which is associated with mild upper respiratory tract infection to severe acute respiratory syndrome, severe acute respiratory syndrome, ARDS. All right, the bacterial agents that cause respiratory tract infections, the upper respiratory tract infections, the bacteria include the Streptococcus pyogenes, which is the common cause of strep throat or sore throat, as we're going to see. Tonsillitis, we have Staphylococcus aureus, which can lead to sinusitis or post-viral secondary infections. All right, the lower respiratory tract infections, the bacterial agents are the Streptococcus pneumonia, which is the common cause of community-acquired pneumonia. All right, we have the H influenza associated with acute bronchitis, pneumonia, all right, and cause of secondary infection. Atypical agents like mycoplasma pneumonia causes atypical pneumonia, especially in young adults. We have the Legionella pneumophilia, all right, which causes the Legionella disease, which is often linked to contaminated water systems. The reason why it's important for us to know the common organisms causing this infection is due to the choice of empiric antibiotics or antiviral agents that may be used empirically for these infections. Fungal infections, less common, but typically seen in immunocompromised individuals where the Aspergillus species, which causes invasive aspergillosis, the Cryptococcus species, which leads to pulmonary cryptococcus. We have the Histoplasma capsulatum and Coccidioides species. These are causes of endemic fungal infections in certain geographical areas. Sometimes we have mixed infections where viral infections can predispose patients to secondary bacterial infections. For instance, influenza virus may be superimposed with bacterial pneumonia. All right, so these are some of the etiology. Pathophysiology, we need to look at how respiratory tract infections develop. All right, transmission, it could be airborne, all right, from droplets of coughing and sneezing. Sometimes it could be due to direct contact with contaminated surfaces and secretions, and that's why, just for us to, say it here, that's why a lot of times I tell people don't, touch patient's bed when you're doing your round. And it's also very important that surfaces of, our OR and our IC should be regularly decontaminated because transmission of organisms causing respiratory infections could occur from direct contact with some of these surfaces. All right, so after contact transmission, the pathogens attach the epithelial cells using adhesins, all right, or viral glycoproteins, especially with the influenza virus, all right, and this can lead to bacterial biofilm formation, which will enhance colonization, especially in chronic infections. All right, and this will lead to disruption of host defenses. We're going to see some of the common barriers to pathogens invading the respiratory tracts. All right, so, but destruction of host viruses vis-a-vis mucociliary dysfunction, viruses like influenza and RSV damage ciliated epithelial cells, which reduce mucociliary clearance. Smoking and pollution exacerbate mucociliary dysfunction. Then there are sometimes some of these, especially bacteria, Streptococcus pneumonia, may evade phagocytosis using their capsules, while viruses like the RSV suppress interferon production, which will delay immune activation. And all of this will lead to inflammatory response, the 3 R's. All right, the pathogens are recognized by the toll-like receptors, which are present on epithelial cells, and macrophages detect pathogen-associated molecular patterns. All right, so once the immune system recognizes the pathogens, there's a release of pro-inflammatory cytokines, such as the interleukin-1, interleukin-6, tumor necrosis factor alpha, and all of this will trigger fever and systemic symptoms. And after that, the immune cells are recruited, especially the neutrophils and the macrophages, which migrate to the site of infection, and this will try to contain the infection due to local inflammation. Then the epithelial damage and cytokine release will occur. Excessive inflammation can lead to tissue damage, and you can have respiratory failure. Down lower in the lower respiratory tract, you can have inflammatory mediators, increased vascular permeability, causing fluid leakage into the alveoli, leading to pulmonary edema. Once the alveoli are filled with exudates, there's impairment of gas exchange, which can lead to hypoxia. Severe cases may progress to acute respiratory syndrome with diffuse alveolar damage and respiratory failure. All right, so that is the common pathophysiology of respiratory tract infections. All right, so this slide is just to give us a table, all right, where we have the common infections as it affects both the upper and the lower respiratory tracts. We have the common cold, sinusitis, pharyngitis, and all that. We're going to be looking at it more closely as we progress. So let's go down to upper respiratory tract infections. All right, so the first clinical scenario here, I hope we can see it. All right. So a 17-year-old student presents to the clinic with complaints of sore throat, fever, difficulty with swallowing for the past 3 days. All right. On examination, there's erythema of the pharynx with exudates on the tonsils. The patient reports no cough, but has tender cervical lymphadenopathy. All right, so the question is, name the most possible causative bacterial agent. All right, what are the components of central criteria? Describe your diagnostic approach. How will you manage this patient? And enumerate the complications of this diagnosis. Can anybody take a go at this clinical scenario? Are you still there? Can you hear me? Hello, can you hear me? Why is everybody quiet? Okay, so anybody want to take a go? What is your diagnosis and what is the possible positive bacterial agent for this case? Anyone? Any attempt?
Hello, Prof.
Yeah, Jonathan.
I think this could be tonsillitis. I think it could be from the strep species.
Okay. You think it's tonsillitis? Anybody?
Hello, Prof. It could be pharyngitis, sir.
Pharyngitis, okay. So what is your...
I think streptococcus pneumonia infection.
Streptococcus pneumonia or Streptococcus pyogenes? Which one? Choose one.
Pyogenes.
Okay. So have you heard about central criteria for diagnosis of pharyngitis?
No, sir.
Okay. Has anybody heard about central criteria for diagnosis of pharyngitis or sore throat? Jonathan, they said the patient has sore throat, so it's not tonsillitis, all right? It's pharyngitis. I hope you understand that. All right, and the commonest agent is Streptococcus pyogenes. Anybody has heard about central criteria? Anybody?
No,
Lucy, you want to say something?
no, sir. I've not heard about it.
Okay. All right. So I assume nobody has said about it. Okay, you'll hear about it today. All right. Anybody? Okay. I thought somebody was saying something. Okay. The second clinical scenario, a 5-year-old child is brought to the emergency department with a high fever, difficulty breathing, and drooling of saliva. The child is sitting in the tripod position, appears anxious, and has respiratory stridor. The patient has not had any Haemophilus influenza B vaccination before. So what is your most likely diagnosis? What are the likely etiological agents for this case? And describe how you manage this patient. Anyone? Nosifo, you want to try? Yeah.
Yes. I think it's a croup, secondary to Haemophilus influenza virus. And yeah.
What is
So for
croup?
the
What in this history gives away croup?
it's because of the patient's drooling and the stridor.
Okay.
Yes, Prof.
Yes, go ahead.
I would think of epiglottitis.
Okay, you think about acute epiglottitis.
Yes.
What in the history gives it away?
I think the issue of drooling as well as the positioning of the patient is typical of epiglottitis, the tripod position.
All right, I agree with you. Nocifo, it is acute epiglottitis. All right. So what are the likely etiological agents? Ken.
The common one being Haemophilus influenza.
Okay. John Claude, you want to say something?
Yes, it was Haemophilus influenza type B.
Beautiful. Okay. How will you manage this patient? What is your priority here?
So the priority for this patient is mostly the nebulizations with steroids and provide the vaccine for Haemophilus influenza type B.
Yeah, vaccine will be for prevention, but this patient, are you going to treat this patient as an outpatient or you're going to admit this patient as a medical emergency? Are you going to send this patient home? Or what are you going to do?
I will admit the patient as an emergency and then manage accordingly, not as outpatient.
Okay. What is the commonest complication here that you want to avoid, which is very life-threatening? Nocifo.
You can worry about the patient's airway, Prof, that if it progresses, then the patient may not be able to breathe.
Yes, you can have complete airway obstruction because of the acute epiglottitis. All right, and that is a worrisome thing, and that will be your priority, airway management. Okay, Ken, is that what you wanted to say? I saw you were here, but you.
Yes, sir. Yes, sir. That's what I wanted to say.
Yeah, airway management is a priority here. Okay.
I think such patients too should not be stimulated. They should not be allowed to cry. They should not be allowed to suffer pain. So those are risk factors for having the upper airway obstruction and the laryngospasm as well.
Yeah.
Then I think in the management, there's room for nebulization with adrenaline to also help. Yes.
Great, great. The first thing is to be able to make a diagnosis, and you want to prevent life-threatening complications like complete airway obstruction. Good attempt, guys. All right, sorry. So a 65-year-old patient with a history of hypertension presents to the clinic with a 3-day history of fever, cough that is productive of yellowish sputum, and shortness of breath. Physical examination reveals crackles and bronchial breath sounds in the right lower lobe zone. What is your likely diagnosis? How will you manage this patient? Anybody want to take a go? What does this patient have?
Prof, I think he has right lobar pneumonia.
Sorry, Jessica.
I think he has right lobar pneumonia.
Okay. What kind of pneumonia is this? Is this, I want you to qualify it because your empiric antibiotic would depend on it.
Community acquired pneumonia.
Beautiful, community acquired pneumonia. All right, community acquired pneumonia. All right, what is the commonest causative agent for community acquired pneumonia? Hello? Nosifo and Ken.
Strep pneumonia, Prof.
Streptococcus pneumonia. Yes. What is your Ken? What is your broad spectrum empiric antibiotics you will use that will target Streptococcus pneumonia?
I think the third generation cephalosporins are good with them. So.
No, we're not going to write that in
Ceftriaxone.
your, no, which of the Ceftriaxone, correct, Ceftriaxone.
Yes, sir.
All right,
Yes.
if you're going to use fluoroquinolones, which one will you use? I agree with you, cephalosporin, but fluoroquinolones that have better lung tissue penetration.
Just ciprofloxacin.
Ofloxacin.
No ciprofloxacin, no?
Ofloxacin, sir.
No?
Levofloxacin.
Levofloxacin, Damilola Osenin, levofloxacin. Think about lung, think about L, and you have your levofloxacin, all right?
Thank you, sir.
Yes, sir. Thank you, sir.
All right, so let's move. Great try. Please, I want everybody, I'm only having only 3 people responding. Let's respond more because I want to stimulate you before I give you the answers. It's important so that, you know, when you see this in the exam, you know we have discussed it, okay? All right, so upper respiratory infection, like we mentioned before, is a self-limiting re-irritation and swelling of the upper airways, which is associated curve with no proof of pneumonia, okay, and lack a separate condition to account for patient symptoms. And there is no history of COPD, that is emphysema and chronic bronchitis. Like we said, they involve structures above the vocal cords, the nose, sinuses, pharynx, the larynx, and the large airways. So common cold, the most common viral agent is rhinovirus, all right, for common cold. And the way I try to remember is the running nose. So running nose rhinovirus, all right? So the commonest viral cause for common cold is rhinovirus, all right? We have other viruses like influenza virus, adenovirus. Adenovirus is actually an enterovirus, and we have the respiratory syncytial virus. The bacterial agents may cause up to 15%, all right? And the most common cause is the Streptococcus pyogenes, a group A Streptococcus, all right? So I don't want to waste much time here because we have a lot of things to talk about. All right, now preventing measures, all right, to, you know, preventing upper respiratory infection, we have HMAC, all right, the air lining, the airway, the upper airway, it helps to prevent pathogens from, you know, passing through. So the air linings in your nostrils helps to trap pathogens, okay? And that's why it's not advisable to remove the air under your nose completely. You know, some people, they clear the air. It's useful, all right? It helps to trap pathogens. The mucus also traps organisms, and the angle between the pharynx and the nose prevents, you know, microbes, particles from falling to the airways. Ciliated cells in the lower airways, all right, also help to limit, passage of microbes down the lower airway. So they try to get the pathogens back to the pharynx where they can be cleared out. The adenoids and the tonsils also contain immunological cells that attack pathogens. So if you're asked the barriers, some of the barriers that prevent upper respiratory tract infection or that try to limit the passage of pathogens, just remember HMAC, all right? Or you can call it CMAC, whatever you want to call it. But the hair lining, the mucus production, the angle between the pharynx and the nose, the ciliated cells, and the adenoids and tonsils. All right, so the common flu, all right, when you hear people say, I think I've got the flu, all right, so it's usually called influenza, all right, and which is a contagious respiratory infection caused by influenza virus. All right, it is believed that they can be transferred among humans by either direct contact, indirect contact, droplets, or aerosolization. All right, short distance or less than 2 meters. You remember the 2 meter distance that we were told to observe during COVID. All right, so this short distance less than 1 meter is usually required for contact and droplet transmission to occur between infected individuals and susceptible individuals. Airborne transmission may occur over longer distance, all right, maybe more than 1 meter. So the 2 meter, what did they used to call it during COVID? All right, social distancing, all right, was actually implied to reduce transmission of influenza virus and the COVID-19 virus. Okay, so the common viral agent is the influenza A, B, and C, but the most common are the influenza A and B. And we have some types of influenza A, the H1N1 and H3N2. So clinical features include FATs, okay? Fever, aches, all right, myalgia and joint pain, arthralgia. We have cough and nasal congestion, and the patients have fatigue, tiredness, and some of them, they present with sore throat. So these are some of the common clinical features of influenza or the common flu. All right, the treatment is also fats, fluid hydration. You want to give the patient, keep the patient hydrated. All right, antipyretics, vitamin C for immune support, temperature control, all right, to manage fever and chills. And we have symptomatic relief, which are nasal decongestants and cough suppressants. For severe cases or high-risk group individuals, patients with cystic fibrosis, or patients with immunocompromised status, all right, you may want to give them antiviral agent. All right, the Tamiflu or the Ostamivir is an oral agent, all right, and it's effective against influenza A and B viruses. We have the Zanamivir, the Relanzan, it's inhalational powder, which is also effective for both influenza A and B, and the Peramivir, the Rapivir is the IV formulation for patients who may not be able to tolerate orally, all right? The annual influenza vaccination is promoted to prevent it, especially during susceptible periods, during winter and all that. So it's during winter, you can't fly to certain countries, all right, if you do not have your flu vaccine, which has been promoted, and I'm sure we're all familiar with it. All right, so annual influenza vaccination is promoted to prevent, all right, the incidences or the occurrence of influenza, and it also reduces the severity of the infection. Complications, like I said, especially immunocompromised individuals, patients on steroids, and all that, so patients who are on chemotherapy, they can come down with primary influenza viral pneumonia, which has very terrible prognosis. You can have secondary bacterial pneumonia, which is strep pneumonia or Streptococcus pyogenes, sinusitis, otitis media. All right. Know that pneumonia is one of the most common complications of influenza illnesses in children. It contributes significantly to morbidity and mortality. Okay, I'm not going to spend time on here. Sinusitis. Okay, let's go to sore throat or pharyngitis, like the first case the case scenario that we had. All right. So pharyngitis is inflammation of the pharynx, which is usually associated with pain and difficulty swallowing, and is a very common infection. Of course, about 120 patients per year for 2,000 patient practice. All right. But a lot of times, only 1 in 18 episodes lead to a consultation. The etiological agents could either be viral and bacteria. All right. The common cold, the rhinovirus, is also the commonest cause of pharyngitis, which is a common viral cause, which accounts for about 25%. The influenza adenovirus, they have the equal, possibility of causing it. The herpesvirus and Epstein-Barr virus, less than 1%. So for viral, I have rhinovirus, which is the common cause of common cold. Then bacteria. The bacterial infection, the commonest cause is the group A streptococcus or the group A beta hemolytic streptococcus, specifically the streptococcus pyogenes, all right, which is common in children, all right, about 15 to 30% in children and 10% in adults. All right, the gas infection, that is group A streptococcus infection, is self-limiting irrespective of whether it's children or adults. And within 3 days, in 40% of cases, the effect wears off, and in 85% of cases, within 7 days, the symptoms should have waned. All right. So we know the infection, the pathophysiology, there's infection of the pharyngeal mucosa leading to inflammation and erythema. This may lead to lymphocyte involvement, leading to tonsillar enlargement, and bacterial infections may lead to suppurative complications. So you have sore throat and pain with swelling, fever, enlarged and erythematous tonsils and exudates. We have cervical lymphadenopathy. All right, for the viral causes, you can have cough, rhinorrhea, don't forget rhinovirus, and the bacterial pharyngitis. The patient will come down with high fever, absence of cough, and tender lymph nodes. All right, and this leads us to the classical presentation of group A streptococcus pharyngitis. All right, and just don't forget the gas. All right, so you have grade high fever. All right, it's deliberate, high grade. So I change it to grade high fever because I want to make the pneumonias gas. Then you have anterior cervical lymphadenopathy. All right, palpable lymph in the anterior cervical area, and you have sore throat associated with denophagia. All right, complications, we have it could be suppurative or not suppurative. Okay, you have please, can you mute yourself, please? Mute yourself. All right, so the suppurative, we have the peritonsillar abscesses. All right, we can have retropharyngeal abscesses. These are very terrible complications which can lead to airway loss, and sometimes this can actually be life-threatening. We have cervical lymphadenitis. The non-suppurative, the acute rheumatic fever. All right, post-streptococcal glomerulonephritis. So the sore throat may look, innocent, but if not treated and complication arises, you could have some of these terrible complications I've enumerated here. Okay, so let's go to the central criteria. All right. Now, the second criteria is a 4-point scoring system that is used to assist with risk stratification for gas pharyngitis, and it also helps in decision making. All right. The 4 components of central criteria are formulated into a mnemonic called FATIs. So the first thing, for you to make a diagnosis of pharyngitis is a fever. There will be fever. All right. There's absence of cough. All right. Unlike when you have other causes of pneumonia and all that. So there's absence of cough. Then we have tonsillar exudate and anterior cervical lymphadenopathy. These 4 components are scored 1 each. The modified criteria includes age. So less than 5 years, less than 15 years, you had 1 point. Between 15 and 45 years, you give the 0.0, and any age above 44, you -1 from the point. All right, so the central criteria is used for clinical decision. All right, so this is what we have here. So if you have a central criteria total point of between 0 to 1, all right, the likelihood of streptococcus pharyngitis is less than 10%. So there's no need of testing and no antibiotics needed. All right, if the central point criteria point is 2, the likelihood of streptococcus pharyngitis is between 11 to 17%, and you may need to perform through swab, all right, or rapid antigen test to confirm it. But when you have a central point of 3, all right, we have moderate to high likelihood of streptococcus pharyngitis, and you need to perform throat MCS and or rapid antigen test. And for central point, total point of between 51 to 53%, all right, total point of 4, the likelihood of streptococcus pharyngitis is very high, all right, most likely, 50% chance. And here you want to consider empiric antibiotic use, okay? And this is important, especially, so that you don't abuse antibiotics and you don't want to withhold antibiotics for patients that need them. Okay, so like I mentioned, apart from diagnosis, it also helps you to decide who will benefit from antibiotic treatment for patients who are suspected to have streptococcus pharyngitis. So you want to apply the central criteria, the FATI I mentioned before. Is there evidence of fever? Yes, fever, all right. Is there no cough, absence of cough? Then you have presence of tonsillar exudate, and you have the anterior cervical lymphadenopathy. So, like I mentioned, if the center is 0 to 1, center point 0 to 1, the patient most likely does not have group A streptococcus infection, all right, and antibiotics unlikely to be beneficial, all right, so you just do supportive or symptomatic relief or treatment. But when you have center 3 to 4, the chances becomes higher, between 40 to 60, and you want to give the patient antibiotics. Okay. Now, trust for diagnosing antibiotic, of streptococcus pharyngitis, usually not carried out routinely, all right, in the outpatient department. But sometimes it may be good if your center is above 2 to 3, you want to be able to identify the causative bacteria. A positive throat culture for group A streptococcus makes the diagnosis of streptococcus sore throat likely, but note that a negative culture does not rule it out. All right. In addition, symptoms of sore throat does not correlate very well with results of your throat swab culture. So a patient may have severe symptoms and the throat swab may be negative. All right, and not also that it's not sensitive or it's not specific, and especially if you think about the increased cost that this patient may have. So throat swab here and there some primary care physicians may want to do it, but it does not really confirm or negate diagnosis. Other tests, the rapid antigen detection test, the serological test, you want to do your PCR test, especially to rule out viral pathogens or atypical bacteria. Additional investigations like your complete blood count to check for leukocytosis or atypical lymphocytes, especially in case of Epstein-Barr virus. Chest X-ray if you worried about lower respiratory symptoms or complications. For patients with GERD, all right, gastroesophageal reflux disease, all right, you may want to do endoscopy. So treatment, empirically, penicillin V, all right, at 250 milligram BID or TID in children or 500 milligram BID for adults. For 10 days, all right, penicillin is a narrow spectrum beta-lactam agent that has the activity against streptococci, including group A, all right? But it's not that it's not active against penicillinase producers, for instance, the Staph aureus, which may cause complicated lower respiratory tract infection. Note that penicillin is only indicated for pharyngitis and it should not be used in severe disease or systemically unwell. Alternative, you can use amoxicillin or piperacillin, and sometimes in severe cases, you may want to use amoxicillin and add a macrolide like azithromycin. All right, so we'll talk about this. Let me look at the time. We may just, okay. For acute epiglottitis, that is our second clinical scenario we mentioned. It's a medical emergency because it's a life-threatening condition that is characterized by inflammation and swelling of the epiglottitis of the epiglottis, all right? And it can cause complete airway obstruction. So we have both infectious and non-infectious causes, the viral, all right, the H influenza type B, and we have the bacterial streptococcal pneumonia, and the Staph aureus, viral infections like varicella zoster. All these are the common infectious causes. Sometimes you can have non-infectious causes like thermal injuries, all right, trauma, direct injury to the throat, and sometimes it may result from allergic reactions. All right, if you look at, what's going on? If you look at the right, you see this, the epiglottis, all right, the leaf-like structure, all right, among the laryngeal cartilages, all right. You see this is inflamed, and this is what will happen, causing airway obstruction because it narrows the airway. These are the vocal cords. So this is inflamed epiglottis, all right. So infection and irritation leads to inflammation and edema of the epiglottis and surrounding tissues. Swelling will lead to obstruction of the airway with impairment of airflow to the lungs. And this may progress very rapidly with potential for complete airway obstruction. All right, so for acute epiglottitis, the clinical feature is characterized by staph, all right? And by now, I'm sure you know I like pneumonia, staph. So sore throat, we start with sore throat with dysphagia and drooling of saliva, all right, due to inability to swallow. This can also be associated with stridor, with tachypnea and rib retractions, all right? Tripod position, you can see this child, all right? Tripod position, sitting. Sometimes during clinical exam, we may ask you to describe the tripod position that patients with acute epiglottitis usually assume, all right, is to gain mechanical advantage and try to improve airflow into their airway. So the patient sits upright, leaning forward with extended neck to maintain airway patency, all right? So that's the tripod position. Patient is anxious and breathless due to hypoxia, all right? Fever, typically high grade, you can have a faint or muffled or hot potato voice. When you're eating hot potato, how do you talk? All right, that is the kind of voice change that occurs in patients with acute epiglottitis is called muffled or hot potato voice. Okay, so look at this picture, don't forget it. This is how the patient presents with acute epiglottitis. All right, so the diagnosis is based on 3 different methods. Clinical diagnosis, this is based on symptoms and physical findings. All right, then you have your lateral neck x-ray, which may show a thumbprint sign, which is indicative, all right, thumbprint, all right, of look at it, this is like your thumb. You can see, try to stick out your thumb, all right, this shows a inflamed epiglottis, all right, it's known as the thumb print sign. You see, it's as if the patient is giving you a thumb up. Look at my neck. There's something in my neck. The thumb is pointing towards the neck. You can imagine the patient pointing to the neck. All right, so it's called thumb print sign. All right, then direct visualization under controlled conditions. Remember what Ken told us. You don't want agitations. You don't want to provoke the patient. You want to limit cry. You want to limit excessive stimulation, because this can actually promote complete airway obstruction. So our management is AMS, all right, airway management is the priority, and this should involve a multidisciplinary team, all right, of anesthesiologists or ENT surgeons, and you should get ready to prepare for intubation or surgical airway, all right? Avoid agitation as it may worsen airway obstruction. Medical therapy, empiric antibiotics, all right, targeting likely pathogens, your third generation cephalosporin, your ceftriaxone of cefotaxime, all right, it can be used empirically. But if you're, especially in cases of methicillin-resistant Staphylococcus aureus, you want to use vancomycin to cover it. Sometimes corticosteroids may help to reduce airway inflammation. And supportive care, oxygen therapy. But I'll divide the mnemonics for you, especially, all right, for anesthesiologists. Sometimes you are called to secure the airway of a child with acute epiglottitis, all right? So you want to, remember heaven. So the first thing is humidified oxygen therapy, all right? You don't want to give the patient dry oxygen, dry air. Humidified oxygen therapy. You want to intubate, endotracheal intubation, and you want to avoid IV induction, okay? You want to avoid IV induction. You want to avoid muscle paralysis for this patient. So this patient should be induced with inhalational agent in a sitting position. Now, this must be clear when you are answering the exam or in your management. You don't want to let the patient supine, because this may complicate airway obstruction. So in sitting position, inhalational induction, and you want to intubate. But what we tell people is that before you intubate, once you have confirmed the patient has acute epiglottitis, this ENT surgeon must be in the OR, all right, scrubbed, ready for surgical airway in any case of failure or difficulty with intubation. So atropine helps, all right, and antibiotics, like we mentioned before, volume replacement, all right, because this patient may be volume depleted, like what Ken said, nebulized epinephrine tries to cause vasoconstriction and try to reduce erythema and the swelling. So heaven is the mnemonics for management of acute epiglottitis with upper airway obstruction. So prevention, routine H influenza B vaccination, and early treatment of upper respiratory infection to prevent complications. All right, complications, CHOP, complete airway obstruction, which may lead to hypoxemia and respiratory arrest. Patient may have edema, negative pressure pulmonary edema, and you can have pneumonia occurring as a secondary infection. Okay, so conditions, this is a summary, and I think we should stop. We can't continue with lower respiratory tract infection because that's another long session. So let me just put off the stop recording, then we can have some discussions